So good morning. So, oh, so slow. Uh, Anyway, thank you for inviting me in this incredible meeting. So I'm very thrilled to be here. It's my honor and pleasure. And thank you very much again, all staff and Dr. Chairman. And it's very nice city. Okay. Oh yeah. And I will tell you now real story of UBE. Okay? Actually, I'm from South Korea, and now I'm working in Abu Dhabi. I'm 3 years. Oh, disclosure. I made a USCOPE with German company, and this is compatible with FESS UBE. And before we dive in, let's talk about the history of endoscopic spine surgery briefly. In 1934, mixed and bar were first disc surgeon, but it was a very traumatic approach. And Kevin and his kata opened the endoscopic spine surgery world. And Dr. Yang make a yes system. And Daniel D. Anthony, 1996, very important person for us. He first presented about UBE technique, bipolar spine surgery technique. Now, UBE is spreading all over the world, but still many doctors are doing monoportal endoscopic surgery. So I want to try to integrate monoportal and bipolar. And as you know, bipolar surgery is a triangular approach. The principle is the same as knee surgery and the shoulder surgery or like that. But spine surgery is a little different. The difference is in knee surgery and shoulder surgery, already there is space. But spine surgery, we have to make a space. That's one of the difference. But it was not easy. So original UBE article is 1996, Daniel D. Anthony published this article. And this is original article. At that time, they cannot use radio frequency device. Maybe because of that, they are doing bipolar surgery in lateral position because of breathing control and problem and retraction problem. So maybe this guy is Daniel D. Anthony. Fortunately, we have some meeting in Argentina, September 4. Maybe I hope to meet him. Okay? And this guy is actually my teacher, Abdul Gappa. Abdul Gappa. Okay. This guy is Abdul Gappa. He's from Bahrain. Actually, he's Indian. He's my teacher. And so at that time, actually Dr. Choi Young-jung from Korean, my senior surgeon, and at that time we met Dr. Abdul Gappa in AAOS, and he visited Dr. Gappa's clinic, but he insisted me. But at that time, during the Mid-East War was happened, so I couldn't. So he visited Dr. Abdul Gappa's clinic, and he recorded all Abdul Gappa's surgery and came back to Korea and discussed. And we developed and established. We aggressively use the radio frequency devices, and I'm neurosurgeon, so in lateral position surgery is not comfortable for me. I changed position, prone position, and we modified some instrument. So I presented about this technique 2003, first biennial Korean-Japan conference. But at that time, no doctor interested. Nobody asked me what's that. One doctor blamed me, one university doctor. Why are you doing this kind of surgery? You must be wrong. Don't do that. At that time, no doctors interested in this technique. But 2003, yes, maybe 10 years passed. So during 10 years, Dr. Son, he's Dr. Son, he's my junior doctor. He approached to me and he agreed this technique is very nice. He want to learn. So we worked together and we developed. And he suggested UBE. Let's call it UBE. So I accepted. And so 2013, in Japan conference, I officially used UBE first. Maybe this date is the birth date, I think the birth date of UBE. So since then, we call it UBE. But before 2013, just we call it translaminar biportal endoscopic surgery like that. And already all doctors know this is Dr. Bach and Dr. Her, and already you know Dr. Bach. So I think there is a learning curve like this, but somebody disagree with that. Level 1 is lumbar laminotomy discectomy. Level 2 is ULBD. Level 3 is endoscopic repair. And foraminal decompression, cervical discectomy, thoracic decompression, and control lateral approach. And then the fusion surgery. Level 4 is X-lip surgery, and cervical control, cervical laminar screw fixation, lateral mass screw fixation, and cervical laminoplasty like that. Okay. What's the next? I don't know. And this is level 1, L45 right side, already you know. And level 2, L45 stenosis, ULBD. And level 3, cervical disc problem. And level 5, biportal endoscopic spine surgery. It was not easy, but we overcome. And sometimes we can use expandable, dual-X expandable cages. I like this cage, but it is very expensive. And level 4, X-lip surgery, we can use only cage in L5 Western level and L45. So we have to prepare, you have to expose all can be triangle. Fortunately, L5 Western level, we can use large cage without any problem, but L45, L34 level, it is a little difficult. The procedure is the same as minimally invasive surgery. Okay, first X-lip article we published with Dr. Her, 2021, and in Korea, maybe over 500 cases were done, and we collect data and analyze about this result. And level 4, maybe 6 or 5 years before I'm staying in Korea, I tried posterior cervical lateral mass screw fixation. It was not easy. It takes 8 hours. I don't want to try to do that. We need some other development, but we can do it. Okay. And pros of endoscopic spine surgery, already you know, we can get a nice visualization and less restriction and less substrate damage, and we can complete decompression around the nerve root because we can see clearly. And also, obesity is pandemic, so we can use possible under local anesthesia. And this is one of factor of ERAS. Yes, obesity is epidemic. And cons are, unfortunately, there is no working space, so we have to make working space. This is maybe first hurdle, I think. Also, second is, it is water-based procedure. We have to think about pressure problem. So multiple levels, we can do it, 1 level, 2 level, 3 level, 4 level, but it takes long time. So we have to think about it. So usually, personally, I recommend 2 level will be fine. 3 level, let's think about it. Let's think about another option. But if you are very, very familiar, very expert, and you can do 3 level, 4 level, no problem. Also, there is a learning curve. So this is my personal comparison. Microsurgery, surgical view is good. PLD is good, but very narrow, already you know. But bipolar is excellent. And instrument handling and microsurgery is no limitation and limited, and nearly no limitation in bipolar surgery. Learning curve is in the middle, and muscle injury, we cannot deny. The best approach is PLD or uniportal. But next is biportal and microsurgery. But clinically, no difference. Also, in the fusion surgery, microsurgery is good. Uniportal surgery, we can do it, but it is very, very difficult. We cannot use large cage like that. For biportal surgery, we can use a large cage, no problem. So challenges are learning curves. So making triangulation is very difficult for early stages. So you have to creating artificial working space. Also, it is not easy. You have to understand, making a good working space is the first key of our surgery. The next is making a good water egress, working portal. We need a working portal, and we need proper water pressure, water passage, and always there is risk of dural injury. Also, I have many cases of dural injury in learning stages. Already we talked about that before. So my concerns about UBE, we have to always think about dural injury. We have to prepare. And also we have to think about intraspinal pressure problems. And also, we cannot solve all the problem with endoscopic surgery. We have to bear in mind. Sometimes we need open surgery. And we talked about dural injury before, and you can prepare everything. And we have to follow the algorithm of the fusion surgery. Even if we are endoscopic surgeon, we have to follow this rule. So I want to talk about small tips for endoscopic TLIP surgery. I want to recommend expose cambium triangle completely. So make a thecal sac and nerve root flexible. Make it flexible. And remove disc enough ipsilateral and contralateral without endoprotective damage. When using shaver and walking, it should be the parallel to the both end prep. And do not put a bone chips before cage implantation if you want to put a large cage. And try to make a good cage position. This picture is, I did this surgery. It's not good. Post-operative patient complain pain. There is no radicular pain, but patient complains pain ears because look at the cage position. And also this patient is, lordosis is a little high and L5S approach is not easy. So left side approach is not easy for me. So I cannot put a cage in a right position, okay? So we have to think about that. And future of UBE, we don't know. The technique is not limit. So we can collaborate with AR and navigation and robotic surgery, but it costs high. But I will try now integration with UBE and for endoscopic spine surgery. I will tell you another story, right? So, AO spine declared like this, full endoscope. So how many doctors are doing by monoportal endoscope? Maybe many doctors, okay, many doctors already experience of monoportal endoscope. Okay? For endoscopic spine surgeries, not microendoscopic, not tubular system, not endoscopic assisted surgery. They are trying to discriminate UBE. I think, okay, UBE is not an endoscopic surgery, just endoscopic assisted surgery. Okay, so that is endoscopic assisted surgery. But surgical view is very nice, no problem. Okay? And evolution is inevitable. So in terminal FESs, there was evolution because they want to try to use a more large instrument. That's one of the disadvantages of monoportal endoscopic surgery. There was evolution, okay? So look at the instrument of uniportal endoscopy. We cannot deny the instruments are usually long. So long lever arm effect, grasping power is weak, and blur to bending forces. They are trying to get over this kind of disadvantages. But look at the standard instrument, very powerful, regardless of cost issue. Sometimes we need a strong instrument. in UBE surgery, we can use this instrument. That is the strong point of UBE. So how to allow standard instrument? So enlarging the working channel, there was evolution. Second method is making a second large working channel. That is, I think, bipolar. And third method, maybe, I break open the working channel. That is ESUBE, I think. I don't know. So I break open the monoportal endoscope, and I remove the upper part of monoportal endoscope. This is uniportal, and this is biportal. Just in the middle position is positioned ESUBE, maybe. Let's review the development of endoscopic spine surgery. Campaign in Hizikata opened the endoscopic spine surgery, and yes, developed yes system, Yang developed yes system. And after since less, yes, we are doing transforaminal and interlaminar FAS. There is evolution, but still they cannot use standard instrument. 1996, D. Anthony first presented about biportal endoscopic surgery. To 2001, since Dr. Kappa, we established present UBE, but still we are using, what are using endoscope is arthroscope, not a spinoscope, not specialized for spine surgery. So I will show the cases. This is a C56 right case, but surgical view is the same as biportal endoscopic surgery. And L5S1, okay, surgical view is the same. Because I use the 4mm lens, we can use a standard instrument. And I tried ESUBE TLIP, L45S1, direct cement cage, but I don't recommend. It takes too long time. And interesting is we can use a dual mode, okay, in the air mode first, and in the water mode. We can do it ACDF. We can see the anatomy clearly, PLL and dura and nerve root. Okay, so we can do a job in a water mode because in the water mode we can see the anatomy clearly. We can see posterior osteophyte clearly. We can decompress safely. Okay, just breathing control in air mode. And we can put a cage. The procedure same as ACDF. And we need some development. So comparison. So in the monoportal endoscope, we use a 2.9mm lens, and the angulation is maybe 10 or 15 or 20 degree. And biportal endoscope, the lens size is 4mm, and the lens angle is 0 degree and 30 degree. For ESUBE, I used the 15-degree lens angle, but the lens size is 4mm, so surgical view is the same as biportal endoscopic surgery, better than the uniportal endoscope. The surgical field is wider than the uniportal endoscope, but the position is just in the middle, maybe. The cons of USS is, unfortunately, the outer diameter is 10mm, a little large, so not so free instrument handling compared to UBE. UBE is the best, especially in the fusion surgery. I recommend the biportal endoscopic surgery because we can use both ends and very free, and we can operation time will not be so long. Okay, but still longer operation time for fusion surgery and learning curve, long-term study. So about the learning curve, microsurgery, like riding a bicycle, UBE is driving a car, ESUBE is driving a flying car. And full endoscopic surgery is airplane operation like that. Okay, very nice, but not easy. So conclusion. So endoscopic spine surgery will be a promising MIS. You can try all kind of endoscope. Let's make a new endoscopic spine world together. Thank you very much for your attention.